So it's a it's a real privilege today to introduce the Aresti Cardiology Grand Rounds. The Aresti family has been generous enough to sponsor this Grand Rounds in honor of Julie. Many of you know Julie, had the privilege of working with him throughout his career at the BI. I think from my perspective, Julie really is, he's one of my mentors. He's one of the people who really represented the best of this institution. He was the consummate doctor's doctor, an incredible clinician, an incredibly bright person with a tremendous curiosity, not just in his own practice and scope and expertise in general and interventional cardiology, but really an incredibly open, nimble mind with an interest in everything. And I can remember when Mark brought EP to the BI, Julie's interest and his willingness to engage in the new ways of thinking that Mark was bringing to the institution, and a willingness to change his practice and adopt these new things. And I think that really characterized his career and kept him fresh and current till the last day that he practiced. And he still remains involved in this division, often asking the most insightful questions, as you've all heard in Grand Rounds. Julie also was, a complete gentleman, and always treated everybody with respect. I think we can all, Joe probably feels this way as well. Always, even as an intern, feeling like your opinions were valued in his patients, and you could ask him anything and call him at any time of the day or night, and he would treat you the same as you would treat his colleagues or the chief of cardiology, which was quite remarkable, and I think set a tone of professionalism and decency, which we should all aspire to. In many ways, our speaker today, Andre, is, I think, carries many of these same traits and has brought them to this next phase of EP at the BI. So Andre, you all know, is an international figure in cardiac arrhythmias and in understanding and treatment of complex arrhythmias. He is from Brazil, where he spends now 20% of his time. He trained in Brazil. He's trained with luminaries all over the world in electrophysiology. Spent some time in Boston, got to know our program a little bit, and we were lucky enough to, when we were ready to recruit a new chief, to get him to come back here. And in the short time he's been here, through the pandemic, has really transformed the service. He's brought a new way of thinking about ventricular tachycardia and how we should approach this in the lab. He's done it in a multidisciplinary way. He's, as evidenced by some of the variety that we're seeing on the meeting today, he's worked closely with radiology, with Diana, who's I think watching, and hopefully with Reza, and really is going to bring together the ability to bring all the strengths of cardiac imaging at this institution to the EP lab, and hopefully take us into a new era of the treatment of VT. So with that, I'd like to turn it over to him and thank both Julie and his family and Andre for today's discussion.
Thank you, Peter. Thank you. Thank you for the opportunity to present today. I'm in Brazil, so after 3 days here, the English gets a little bit rusty. I'm sorry for that. So I'm going to try to discuss what we are trying to do at BI and what we're trying to offer your patients in terms of VT ablation. As you all know, because of several contributions from Mark, it's became very clear that the most relevant mechanism for VT after MI is a reentrant tachycardia. The reason for that is because we have surviving bundles of myocardial in the middle of the scar. And these portions of the survival bundles inside the scar are the substrate for VT, for the reenter circuit to happen. Because of the mechanism and because of the existence of these bundles inside the scar, our classic approach in terms of mapping and ablating VT would typically require VT induction. We would also try to define the substrate based in voltage, And then to validate the electrograms that we had, that we could see inside the scar, we would have to induce and use EP maneuvers, which we call entrainment, to validate if those areas, those electrograms were essential for our VT or not. Once if we were happy with those electrograms, we would then ablate and retest with a re-induction. But the field of VT ablation is quickly changing over the last 10, 15 years. We are now trying to map more in sinus and during pacing to recognize, to identify areas that are critical for VT inside the scar, which requires less VT induction. And all of this, it can be done independently of voltage. So instead of burning simply the areas of low voltage, we'll burn less inside sometimes a large area of low voltage, a large area of scar. And for us to do this safely and more effectively, we're now using image to guide our ablation procedures. And because of this, we can also incorporate new ablation modalities, which we'll not discuss today, but this would be a topic for another presentation sometime in the future. Over the years, starting with pioneer work from Mark Josephson, establishing the mechanism and also the treatment, the initial treatment for VT with the endocardial peeling, the surgical treatment for VT, several different contributions evolved from a simple tracing like this in the late 70s to a completely different concept in terms of VT. Instead of looking at the problem based on electrograms, we can also create, based on this kind of electrograms, different ways to look at the same phenomena. And we can now locate the circuits in different areas of the wall. And there are several contributions over the last years. My interest in VT has been long. So this is my very first paper in VT in 1994, when I was first year fellow in Belgium with Pedro Brugado. I was 30 years old, I'm 56 now. Just to put this in perspective, a friend of us who you know well, Roderick Tang, graduated from high school in 1994. So this has been long 26 years. But I was fortunate enough to witness a lot of changes over the last 25 years in terms of VT. Let's get to the point. Let's say that we are dealing with this patient that you see on the screen. This is a man with known CAD who had a previous MI, single vessel disease, only LAD infarct, one of those old substrates that we used to see in the past. Apart from that, he was kind of healthy, but was having several episodes of syncopal VT despite a amiodarone that he was using to control his PVC. So what are the treatment options that we have for this patient here? Should we consider ICD, antiarrhythmic drugs, ablation, surgery, all of the above but surgery? Or we just don't know and we don't care, we just call the EP guys and they will decide what the best approach is for the patients. As you know, this patient would be a class 1 indication for an ICD implant, but ICDs are not the ideal treatment for VT. They're actually the most painful treatment for VT ever because shocks are extremely painful. So even though the ICDs are very good to prevent sudden death, they cannot be used to prevent VT recurrence. This is not what they're made for. There is a different option for that. If we decided to play with antiarrhythmic drugs, the most effective antiarrhythmic drug out there is amiodarone, especially in patients who were naive in terms of amiodarone treatment. For those patients who experience VT and were already taking amiodarone, escalating the dose or adding a second antiarrhythmic drug does not help the patient. The best option, if that's the case, is to offer the patient an ablation procedure. The problem with amiodarone, as you know, are the potential side effects, which will limit the use of this good antiarrhythmic drug in many different situations. The ideal treatment for our patient here with a very specific substrate, which is an LAD, single LAD infarct, would be an approach that would help control VT, improve his left ventricular ejection fraction, and potentially treat residual coronary artery disease, residual ischemia. So in the past, and this is just an example for us to understand where I want to go, there was an approach that we're using here in Brazil, which was a surgical removal of the aneurysm located on the anterior wall. And we're also plicating the septum wall here. By doing so, we were able to dramatically improve the ejection fraction of these patients, and at the same time, treat VT quite well. As you can see here, those days were days without an ICT. So the VT recurrence in this population was very low. What's interesting is that despite of treating VT, treating ischemia and improving LV ejection fraction, the mortality rate was still important, around 50% after 6 years. And this is something that we need to keep in mind. Patients with VT are sick patients. Even when we treat VT, they can have a limited survival because of the underlying heart condition. Another important piece of information that we can take from this initial experience, the surgical experience like 20 years ago, is that in some substrates, not in all, but in some substrates, we can properly treat VT without the need for mapping, intraoperative mapping or mapping in the EP lab. It would be fantastic if we could recognize this kind of substrates and bring these patients to the lab to ablate or to take them to surgery without the need for several VT inductions, because as I'll show you in a minute, in some patients, VT inductions is not a good thing. This is a case that we had at BI, I think 2 or 3 weeks ago. It's a similar situation to the patient that I presented to you in the previous slides. It's also a patient who had a apical aneurysm due to single vessel disease. And this patient experienced a VT storm and went into monomorphic VT and was stabilized with some antiarrhythmic drugs and referred for ablation. The difference here now is that this is a CT that was acquired from this patient. And as you can see here, we can characterize the substrate in a completely different way using imaging. What you see here, the color codes here represent wall thickness, being this dark red, a very thin wall, and the yellow would be a 5-millimeter wall. And then as you can see, you can trace potential channels of surviving bundles of myocardial that should be located. They have a higher chance of being located in regions where you don't have a very dense scar. So, but how can we ablate such a huge substrate using the simple tools that we have? How can we make such a huge scar non-inducible, not able to sustain VT, by simply using a small catheter that can create a small lesion, lesions that are no bigger than, no larger than 4 millimeters in healthy tissue and smaller than this in scar tissue? The way for us to understand what we do in the lab, it can be summarized here. And I will not present many tracings, EP tracings to you, but this is just a basic one that I would like your attention for a second. This is a patient that was ablated. And as you can see here, the patient had this VT, had a bad heart function here, a calcified MI in the inferior wall. And despite of that, despite of this huge substrate, we were able to stop his VT within 2 seconds of RF application with a very small lesion there. The way for us to decide where to ablate is based on electrograms. As you can see here, when we are mapping the endocardial surface of the heart in this particular patient, we are able to localize, to visualize these potentials, these abnormal potentials, which we will call late potentials because they happen in sinus and during RV pacing after the end of the QRS. And using some EP maneuvers, we can prove that this specific electrogram is actually essential for that VT. So as you can see here, when we induce this tachycardia, this potential, which was late in sinus, becomes a mid-diastolic potential that we validate using different maneuvers. And once we decide that this is important for the VT, and we apply there, we can immediately stop VT. Those electrograms are typically located in what we call protected isthmus. The isthmus is so-called protected because it's actually a bundle of surviving myocardium surrounded by scar that will connect different portions of the scar to each other. This is a classic paper from Dr. Jacques de Barker. He was one of my mentors. He gave this to me many, many years ago. And this is an extremely important paper. So as you can see here, they took a slice of the eye and they were able to navigate within this slice, as you can see here. And look at that. So this part of the surviving bundle, represented here in black, will connect to the other side of the scar through this small bundle here that connects in a different level to this here and bridges all the way to the other side of the scar. When I ablate, the goal is not to eliminate all of this, but if I'm able to recognize, to locate this small bundle, then I might be able to make this whole scar non-inducible anymore, because I'm going to destroy the only pathway that the VT needs to sustain. These bundles, they can be located in different portions of the wall. They can be entirely located on the endocardial wall, which typically happens in post-MI patients. They can be exclusively epicardially located, which happens most frequently in patients with ARVC and in patients with non-ischemic cardiomyopathy, but not always. And they can be, the vast majority of these cases are actually three-dimensional. Part of the circuit happens, it's closer to the endocardium, part of the circuit happens in the mid-wall, and part of the circuit may happen on the epicardial wall. Depending on the location of the circuit, we have to use different strategies. The one I just showed you before, it's an endocardial map and ablation there. But if the circuit is predominantly located on the epicardial wall, there is a technique that we're able to enter the pericardial space with a needle. This is a dry pericardial space, does not require the epicardial fusion. And then we can navigate the ablation catheters inside the pericardial space. This is a technique that we described with the group of the University of São Paulo in 1996, and it's became like the main approach for epicardial circuits up to this day. Last year, we were able to, 25 hours after the initial description, we were able to publish this book. And this technique has been, it's the standard technique when we are dealing with 3D or predominantly epicardial circuits. Let me show you a typical epicardial circuit. This is a basketball player, 27 years old, with syncope during exercise, a relatively normal LV function, as positive signal average. And as you can see here, there is a scar presented in the infralateral wall, which is the wall where epicardial circuits predominate. So the patient had this inducible VT here. And in sinus, once again, we are able to identify those late potentials happening after the end of the QRS. And during VT, those late potentials became mid-diastolic potentials. And once they are target, we are able to stop the VT. Look at that, a catheter placed right in front of this very abnormal potential here. This is an endocardial, this is an epicardial catheter. The endocardial surface is completely normal, as the epicardial surface is very sick, being the substrate for that VT. This is another patient who was on a waiting list for heart transplant, who came to the hospital with incessant VT. We're able to identify the circuit, epicardial circuit around this area here. As you can see, there is a layer of scar, which is much closer to the epi rather than the endocardial surface. And an epicardial ablation, which is this one here, was required to stop and control his VT storm until he got the transplant. It's important to recognize that the prevalence of epicardial circuits vary with the underlying heart disease. It's less common in MI and more common in Chagas in ARVC patients. In Chagas in ARVC, it's very important to go to the epicardial surface during the very first procedure. It's not The same if you're dealing with post-MI patients. We typically start our ablation procedures endocardially with post-MI, and if we do not succeed, or if there are different indications such as pre-procedure imaging suggesting the presence of epicardial circuits, then we can go there. We can also have sometimes circuits happening in the mid-wall. Those circuits are very difficult to ablate, and they may require a specific technique, which is what we call bipolar ablation. Briefly, what we do, we place catheters in front of each other. And as you can see here, as we start ablating between these two catheters, we can cause in several patients a transmural lesion, which is what is needed for you to get to the mid-wall and ablate the circuits. Typically, what happens is that it takes much longer for the VT to stop, which makes sense. If the circuit is located in the middle wall, it won't stop immediately as you start your application, as you saw before. That would stop in 2 seconds. Typically, the mid-wall VTs, they will take a little bit longer when we have to use this technique. As you saw, there are different approaches for us to ablate endo, epi, or mid-wall VTs. The problem that we have with all these techniques is that the validation of the ideal target for VT has to be done during VT. We need to induce and map in VT. It would be great if we could do that with a stable VT, but the vast majority of the patients that we have to deal with, they have unstable VTs, which are not good for mapping. We have to terminate VTs sometimes with multiple shocks during the procedure, and that is not good for the patient. Because of the limitations and the hemodynamically unstable VTs, we decided to run a trial a few years ago using Impella, hemodynamic support during VT ablation. As you can see here, we were using cerebral oximetry to manage the hemodynamics of the patient. It's really impressive. Sometimes the patients you can map a patient with a mean arterial pressure of 4 or 5 without changing the cerebral oximetry. But after some time, when you induce, even the cerebral oximetry will change. And this is something that when you get to this point here, you have to stop VT. With hemodynamic support, we were able to map for a much longer period of time, as you can see here. Despite of that, this is an interesting slide just for you to make the point. This is the beginning of the procedure, but every single time you see a decay, a change in cerebral oximetry here during the inductions, as you can see, the patient never gets back to the baseline. It's a progressive change, compromise of the patient's hemodynamics up to a point that it takes a really long time for the patient to recover, and we are forced to stop the procedure. This is the reason for that is because most of the VT patients that we have to deal with have a low ejection fraction. And this is the node slide from the DFT times. And as you can see here, the ejection fraction will recover quickly if the ejection fraction is normal. But if the patient has a sick heart, after multiple shocks, the LV ejection fraction will never get back to baseline. And this can actually compromise the clinical condition of that specific patient. The problem is that even using Impella and being able to map for a much longer period of time, the overall outcome of these patients was similar to those patients that we were able to ablate without the hemodynamic support, suggesting that the hemodynamic support was important for us to manage the clinical situation of that patient in the lab during the ablation procedure, but would not change the overall outcome. After all of these possibilities, this is what we have right now as our current understanding of the ability of ablation to deal with VT. We believe that for most patients, especially those after post-MI VT, we can offer a 70% freedom from recurrence with an overall combined transplant mortality of 15% in 1 year. Once again, as you can see here, if the ejection fraction is good, VT recurrence will not change the survival. It will do so if you have a VT recurrence in a sick patient. And those are the patients who will benefit more from an ablation. And those are the patients in whom induction of VT complicates the clinical course of your procedure even more dramatically. That's why we need a different solution. And what we are trying to do is to change the ablation procedure, make it shorter, safer. And for us to achieve this goal, we are using different strategies. We are using pre-procedure image for planning our approach. Instead of mapping during VT, we want to avoid VT, hemodynamic decompensation during VT induction. We are trying the best we can to characterize and to understand the substrate. And if we can do so, most of our patients can go home the same day or next day, making an ablation procedure a much more acceptable procedure, just like an atrial fibrillation procedure. Instead of keeping the patient in the intensive care unit for a few days after acute decompensation during the procedure, most of our patients, if we're able to use this approach, can go home the same day or next morning. This is the basis for what we are trying to do there. This is a CT. And Diana is being extremely helpful with this kind of approach. And this is a CT where, you can color code the wall thickness inside the ventricle. And as I said, if you have a very dense scar, this area is less likely to have those interesting electrograms, which are essential for the VT circuit. So if I can see the areas that I have a higher chance of finding electrograms that are essential for my circuit, I can concentrate my map and my ablation strategy in these points. In Europe, they are already using image only to guide ablation procedures. We are not there yet because many of these important electrograms that you can see here are related to some of the channels, but not to others. So it wouldn't make any sense to ablate the entire scar just because there is a potential channel there. There are channels which are essential where these electrograms will live, and there are other channels which are not essential, at least for that specific VT at that point of ablation. So what we are trying to do is to focus, to concentrate our mapping to areas that are potentially important and modify those areas. There is a concept, this is just a colorful figure, but it makes the point. If you have a complicated substrate that it's able to sustain up to 14 different morphologies, why should I try to induce 14 different VTs if I can instead characterize the substrate of all these 14 VTs and destroy the substrate without mapping a single VT? That's the point we're trying to make here. Because of that, this is the workflow that we're now using at BI. We are trying to, as I said before, to minimize the amount of induction. And in some patients, depending on how clear the substrate is during sinus or during some sort of ventricular pacing, we might be able to ablate without inducing VT at all. This is an interesting case. I want to show you a few cases so you understand more clearly what exactly we are doing. Again, we had this patient here with a non-ischemic cardiomyopathy who had a previous endocardial ablation at BI and came to the lab with very frequent VT. As you can see here, he has a few potential channels in these regions here. And this patient was nearly in incessant VT. This is his VT. This is a very interesting VT actually. As you can see here, this is what we call propagation map. It shows the wave front propagating during VT here. And it's interesting, look at this one here. It starts here, gets to this point, then disappears, starts here again, disappears, and starts once again over here. This is a clear 3D circuit. When you see the square, the yellow square here, is because the wavefront is not going through the epicardial surface. It's actually diving deep inside the wall and exploding and showing up again in this region here. So we have an opportunity, which is if this region is essential for VT, I can simply burn this small portion of my circuit and make this VT non-inducible anymore. As you can see here, when I place my catheter for some validation of those electrograms, I can pace in this area, which is what we call the exit of that protected isthmus. And when I do so, my QRS morphology is identical to my VT morphology, suggesting that yes, the entrance of that channel is here and the exit of that channel is here. So between the exit and the entrance is the protected isthmus that I should target to stop that VT. And that's exactly what we did. So patient had mid-diastolic potentials, as you now know what it means. And by delivering a pulse there, we were able to stop VT within seconds. So this was a 3D circuit with an epicardial portion of it that was ablatable from the epicardial surface. We got lucky. That happens sometimes. But what's important is that this mapping during this nearly incessant VT was very similar to the map in sinus, suggesting that if we had no VTs, we would be able to ablate to find interesting electrograms even in sinus. As you can see here, when I trace this little this black circle here, this is an interesting area in sinus, which coincides with this interesting area in VT. So if I had to ablate using my sinus map, I would have gotten exactly the same results. If that's the case, why not to ablate and map in sinus only? And this is the technique that we've been using. It's very simple to understand. White is the earliest area of activation. Purple is the latest area of activation. During our V pacing in this particular patient here, we're able to characterize the potential substrate for VT. We have all the VT needs to exist. We have an area of slow conduction here, which is represented by the isochronal crowding. Each isochrone, it represents 12.5% of the cycle. And when you have a fast propagation, you see in those given milliseconds, the propagation here is very fast, but then it gets to this area, all the isochronals, they get closer. It's what we call isochronal crowding, which is a way for you to characterize slow conduction or block. In this region here, more likely we have lines of fixed block and this whole channel full of late potentials. So I have all the elements that I need to suggest that this is the operational channel for a given VT. What we did, we put ablations in this area to obliterate the whole channel here. And as you can see, the region where the ablation dots were delivered are independent, are at the border of the scar. So we are not using voltage to guide our ablation anymore. If we're doing so, we would have to ablate this entire region of low voltage represented here in red. That's not needed. Instead of changing and ablating the whole scar, I can concentrate in few areas that are essential for the VT circuit. This is another example. It's the same concept. I have here areas of isochronal crowding and an area of very late potentials, which you can see here, creating this potential channel for VT to exist. We ablated this potential channel, as you can see here. The wavefront goes in that direction and comes down here. We ablated the channel, and by doing so, we remapped the region and were able to eliminate the channel, which was the substrate for the patient's VT. All of this done in sinus and retested in sinus without need for any induction. This is a patient that we did at BI a few weeks ago. And for us to try to do this in a more specific way, we are not only mapping in sinus, but we're also fusing our pre-procedure images. And that's why it's essential for us to get these images before the procedure. We're using that to try to understand the channels, if the electrical channels are indeed correlated to the anatomical channels. And what you can see here, it's a perfect correlation. Represented here in purple and white are interesting electrograms, late potentials that you can see here, which were recognized during our map. When we superimpose the images, we can see that that region fits exactly where an anatomical channel was supposed to be. What we do, we use the image now to guide our ablation catheter, and we are going to put several lesions in this region here to obliterate this channel and to make that scar no longer capable of sustaining a VT. There are other potential channels that are not important at this point. They don't have electrical abnormalities. We don't need to focus on them. And as you can see here, is what happens. These are the potentials before ablation, all of this in sinus, and we were able to ablate in that region, and now we remap, and you can see that the propagation here is completely different from what we had before. Those channels, let me play that again for you, which were causing these late potentials here in purple, are no longer there. The channel has been obliterated, and this VT is no longer inducible. As you can see here, when we remap, all the late potentials are gone, meaning that this channel, which was recognized by pre-procedure imaging and mapping in sinus or RV pacing or some sort of ventricular pacing, where we could use this kind of information to guide our ablation strategy to that specific location. There is always a big discussion about if this is enough, because there is no question that functional block, which can only be seen using some specific EP maneuvers or during VT, are part of the circuit. But there is also no question that if we can use image to guide our ablation procedure, is because for sure there are fixed barriers that are very important for the VT circuit as well. When I wrote my old paper in 1994 as a student, I listed 4 main reasons for us not to succeed in VT ablation. I think we're able to take care over the last 25 years of the first 3. And we still need to understand the role of functionally determined VT circuits there. For us to do so, essentially, we need VT, we need to map in VT. But what we are trying to do here is to establish clinical benefit of a VT ablation strategy that are going to ablate in sinus after recognizing potential channels using pre-procedure image and electroanatomical mapping in localized areas, and see if the clinical outcome of this approach is acceptable for most patients. This is at the end of my presentation. This is some of the data that we have generated at the BI. I think we've done 26 or 25 cases since August, and I'm going to concentrate in post-MI patients. These are my last consecutive patients in Brazil, and we've done in total 21 patients. One patient, which is the one I showed you with incessant VT, required 2 procedures. After this, we had 1 recurrence, and 1 patient died suddenly 43 days after the ablation. What I'm trying to show, because of this very, very limited follow-up, is not that this, the efficiency of this procedure, the clinical efficacy of the procedure. I'm just trying to show that at least we don't have a recurrence rate and a complication rate, or we are not being pro-arrhythmic in a way that we should stop using sinus mapping and ablation and move back to VT induction procedures, procedures guided by VT induction. It's clear that in some patients, the only way for us to ablate will be after inducing VT, but it's also important to recognize in a specific subgroup of patients, we can achieve decent, acceptable clinical results without VT induction at all. So what we are trying to do at BI, it's basically we are collaborating with different international groups. We have a huge support from our imaging people at BI, Diana, Reza, the whole team there. They've been very cooperative, and the only way for us to do this is with their help. And we're trying to engage ourselves in different prospective trials. We're working with erotic tongue in a new VT based on mapping in sinus. And we are also trying to work with different protocols combining pre-imaging and selected activation map to define the areas of ablation. We're also working on different options there, but of course, this is the topic for a different discussion at some point. And with this, Peter and Artie, I would like to conclude. I'm more than happy to answer any questions if you have some. I just like to take the opportunity to present our approach to VT at BI. It's an evolving concept. We are going to change over time, but it's just a new way to look at an old problem. And I think we should explore and try to help more people using this approach and understand the limitations of such an approach. Thank you very much for your attention.
Great, Andre. It was a wonderful, wonderful talk. So people can certainly ask questions through the chat. I think that I'd love you to comment sort of on your sense of when we should be thinking about these, bringing these patients to the lab. So we're moving, as I think everybody's aware now, we're moving very much for AFib towards offering ablation as first-line therapy. Largely because it's become a safer procedure, and we recognize that antiarrhythmic drugs are not only limited in efficacy, but are relatively unsafe. What are your thoughts about how we should be thinking about patients with who have ICDs and who are having episodes of VT? Where should this be in the algorithm, and why?
So first of all, there was a huge effort, especially from Mark, in terms of trying to develop some approach that we could justify preventive ablation. In other words, patients will get an ICD and they would have an ablation before the first shock. The study that was done, the SMASH VT study, didn't show any mortality benefit, but it did show a decrease in the number of VT storms over the course of a few years. I'm not sure if you're ready for prophylactic ablation at this point. I think we need to wait for an episode to occur. The problem with episodes, even when the ICDs are treating these VTs properly with ATPs, because of course, if you have a shock, you should consider an ablation as an option. Patients just hate a shock. But even if the patients are getting successful ATP and ATP is taking them out of the VT, the main risk factor for VT storm is lots of VTs. So in VT storm, this is what we really want to avoid by all means. This is terrible for the patient. It complicates the whole management of the patient, even with an ablation. So most centers would accept that if you have 1 or 2 ICD therapies over the last 6 months, this patient should be considered for an ablation. The easiest ablation is the easiest ablation. I was going to kill me if I say so. The easiest ones are the post-MI patients. And I think that if the patient is having these episodes of VT, we should bring them for an ablation procedure, especially because we can now use different approach without the need for VT, as I hope I was able to show it during the presentation, incorporating pre-image of these patients and map and ablate in sinus rhythm, which, the patients can go home the same day or next morning. And I think, again, to answer your question more objectively, 1 or 2 episodes over the last 6 months, it's a reasonable indication for an attempt of an ablation.
Great. So just while we're talking about the procedural aspects of it, Rob asked the question about radiation exposure during procedures, both for the patient and and the operator? How have things evolved to limit that?
We barely use fluoroscopy in the EP lab anymore because we go transeptal. There is a minimal use of fluoroscopy during the transeptal. And sometimes when you're doing the ventricular map, you also need to confirm the position of the catheter. But for the most part, this is fluoroless. We use like electroanatomical maps, and we also use intracardiac echo, which are extremely helpful and prevent us from using a lot of fluoroscopy, which was not the case in the past. Also,
yeah, that's been fantastic. I'm sure Jules in particular would appreciate that as well.
Yeah.
oh, it was very, very common to use 2 hours of fluoroscopy in the past. The machine would heat up and we would have to stop. These days, it's unusual to use more than 5 minutes.
Yeah. And I just want to say thank you also to the Aresti family for support of this wonderful lecture.
Absolutely.
So, for
yeah.
this, right? We now with the new image modalities and the different things, I mean, the amount of radiation for the pre-procedure CT, it's actually much smaller, I guess, than it was in the past. And if Diana wants to comment on that, please feel free to do so.
So absolutely. Warren is asking the question about therapy, non-invasive therapies or less invasive therapies for VT. So radiation therapy in particular for VT. You showed one slide at the end, but maybe you can comment on our approach and where this is going and for whom.
Yeah, Warren, it's less invasive, but the side effects are huge. So we are trying to understand where to use radiation. Of course, you can never use that in a young patient. It shouldn't be the first option in a patient who is clinically stable, because there are different options in terms of catheter ablation. And at this point, and Al and John are actively working on our radiotherapy program there. They can comment on that. But I think it will be offered in some special clinical situations until we understand better the side effects of this therapy. In the literature, there are horrible complications such as LV gastric fistula after some years, after some months of this kind of application. So it's an evolving field, but at this point, it's been used in patients with poor outcome and patients in whom a traditional catheter-based approach is too complicated. But it's evolving. Perhaps in the near future, we're going to be able to do more with less invasive approaches.
Kazi has a question here about the use of non-invasive mapping and imaging to predict patients at risk of VT. Do you think that there's an opportunity through characterizing the substrate non-invasively to define who might best benefit from an ICD and who might be able to avoid having an ICD implanted?
That's the hope. And there are several studies underway trying to explore the concept using MRI and using CT. Of course, the risk stratification that we use these days, it's insane. We look at patients, we look at the echo, we look at the ejection fraction, then we offer them an ICD. And this is really, the result of that is what we all see in clinic. The number of shocks is very small, a lot less than we would expect. So we gotta be able to improve our ability to identify patients who may benefit from ICD, specifically in patients without MI, in patients with dilated cardiomyopathy, non-ischemic cardiomyopathy. In those patients, because of the new treatments for heart failure, these patients will never get a shock. Never get a shock. It's really frustrating when you have to change a battery for a patient who had an ICD implanted 6 years ago, who never had a therapy, despite of a low ejection fraction. Of course, the amount of scar, and not only that, the weight, the shape of the scar will have an impact in the near future in how we risk stratify the fire. I hope so.
Yeah. Rashad wants to ask a question. So can we unmute Rashad?
Hi, Andre. Thank you very much. That was fantastic. Obviously, there's a huge overlap between the advanced heart failure population and the VT population, and I wanted to sometimes it's obvious it's primarily the patient's problem is driven by ventricular arrhythmia, and sometimes it's obvious that it's more driven by heart failure, but a lot of times it's somewhere in the middle. And I wanted to pick your brain about how you sort of your thought process in terms of how you try to differentiate that, or should we just be thinking about these as complementary therapies all the time?
Complementary therapies most of the time. Of course, there are some patients who are very unstable and they have polymorphic unstable VTs. In those kind of situations, you think more about a heart disease as the reason for the VT to happen. But you also have the opposite. Patients with monomorphic sustained VT that you can see clinically or through the ICD. And in those, if they keep having this kind of VTs, this will result in clinical decompensation of the heart failure. Then we need to intervene earlier in those. And for the first, we need to try to manage them more clinically in compensate for heart failure first. But it's complicated.
Yeah. So Dr. Buxton would like to make a comment. Elizabeth, can you unmute Al Buxton?
I want to echo what Andre said about the indications for ablation for VT at this point. The reason why he says that people should be referred after 1 or 2 episodes is that there are multiple studies now that show that outcome of ablation and patient outcome overall is much poorer in people that have had multiple episodes of VT. The results are clearly better when you intervene with ablation earlier on in these people. The other thing that you need to remember, we showed this in a study back in the 1980s and early 90s, is that VT is often, in the coronary patient at least, not the limiting factor on their survival. These people, you can treat their VT successfully, but they still have, because of the underlying substrate, they have very high mortality. And so that's a limitation that our heart failure colleagues need to deal with.
Yeah. Although the substrate is quite a bit different these days than it was in the 1980s, I suspect.
Sure.
So Diana wants to just make a comment about the radiation dose with these planning CTs that we've been doing.
Hi guys, good morning. Great lecture, Andre, and I'm very much, and the entire team is very much enjoys to work with you, and it's very interesting for us. So when we do those CTs, we are working with obviously enhanced studies. While we are working with enhanced studies, we are able to decrease our kilovoltage to much lower than for regular CTs. And that what allows us to overall save substantially on radiation. So when we are doing the study, which is a complex study, has 3 series of images obtained, overall the radiation dose is between 1.5 and 2 times over regular chest CT. Just to give everybody a perspective, we are reaching the realm of between 6 and 7 millisieverts in general. And we can sometimes go even lower than that on smaller patients.
Thank you, Diane. This is really cool.
Great. I think that's it for questions. Andre, it was a really spectacular talk. Julie, I hope you enjoyed it, and thanks to everybody. Thanks to the Rusty family for sponsoring this.
Thank you. Thank you for the
Thank you.
Thank you, guys. See you soon.